Naturally, such patients, when they are initiated on ARNIs, the hypotension may get worsen, they may get postural giddiness, and sometimes there is a lot of fatigue, and that can further aggravate the kidney dysfunction. So we have to be very watchful and optimize the dose so that there is no progression of hypotension. So the important cautions or important tips, those are important in managing such patients are, first we have to see to it that patient is euvolemic. Many times heart failure patients, because of high dose of loop diuretics, they do have hypovolemia and they are hyponatremic. So if we correct the volumes by reducing the dose of loop diuretics, many times we can patients can tolerate ARNIs better. Second thing is, in fragile patients and patients who have borderline blood pressure to begin with, we can start with lowest possible dose of ARNI, that is 50 mg twice a day, and we can go very slow in up titrating doses. Third thing, we can reduce the dose of other molecules which are known to cause hypotension, like mineralocorticoid receptor antagonist, and sometimes we can reduce or change the beta blocker. Let's assume if patient is on carvedilol, which is known to cause more hypotension, we can switch from carvedilol to either bisoprolol or metoprolol, which does not have significant hypotension as a additional effect. We can use ivabradine in higher dose and reduce the dose of beta blocker so that we achieve the target heart rate also, and at the same time we can add up ARNI, and then we can counsel patients about do's and don'ts, that whenever they are changing posture or getting up from sitting posture for initial few weeks or days, they can be a bit slow and take pause before changing posture so as to avoid the side effect. With these small and important tips, we can very well use ARNI in most of our patients with heart failure with reduced ejection fraction.